Good morning. Good morning. Welcome to our first convening for the State of the Health of Chicago, sponsored by the Institute of Medicine Chicago. Today is our kickoff plenary convening entitled No Wealth, No Health. Where do we go from here? Collaboration for systemic change in the time of a pandemic. We can do better together. Next slide. Next slide, please. So just about the Institute of Medicine Chicago, it's a 105-year-old organization and is an independent group of distinguished leaders in the health field who collaborate to improve the health of the public. And we draw upon the expertise of a diverse membership and many regional leaders to address critical health issues through a range of different types of programming. Because of the pandemic, the usual State of Chicago would be held in person somewhere downtown, but today we're beginning this convening online. Next slide, please. I want to thank our Board of Governors, many who joined the call this morning. Next slide. Just to remind you, on October 23rd, the grand convening will take place from 8 to 12:30 p.m. with an opening by Dr. Ezike with an update on the state of COVID-19 in Illinois. We'll talk about the importance of integrated care in the COVID-19 environment, maternal mortality and morbidity in the COVID-19 environment. We'll do an update on kind of where we are with immunizations, what we know now, and what is the plan going forward over the next year. We'll get an update on the Wellbeing Trust Initiative that the IOMC is doing, and then we'll have a wrap up and after convening networking. Next slide, please. On November the 10th, we will have a kind of a quick chat with Congresswoman Robin Kelly to talk about how do disparately impacted communities recover. And this is particularly in line with the work and the interest that the Institute of Medicine has around the social determinants of health. Next. We are confirming the date for Senator Durbin to come and talk to us from a post-election perspective on healthcare in the next 4 years, to update us on where he sees Medicare, Medicaid, and then innovation going in healthcare for our membership and for those else who want to join us. And our last event for the year will be our virtual holiday event. We'll do a 2020 year in review and looking at what progress have we made to closing the health equity gap in the Chicagoland, Cook County area. What have we learned and what do we need to do next? Next slide. I want to thank our sponsors of the Institute of Medicine Chicago for the convening for the State of the Health of Chicago. They include the Portis Foundation, the Micro Research and Education Foundation, the Hectone Institute, the Washington Square Health Foundation, and Next Level Health. Next slide. So we're going to go into our program today, and I'm really pleased to have for our first convening just an extraordinary group of leaders from Chicago and from outside of Chicago to talk about the wealth disparity and health disparity gap, and then identify kind of root causes for the problem, and then roots and solutions for how we begin to close the gap in health disparities by looking at the gaps in wealth disparities and opportunities for systemic change. I've got with us today Dr. Helene Gayle. Dr. Gayle is currently the Chief Executive Officer of the Chicago Community Trust. It's the country's third largest community foundation. Dr. Gayle, is that correct? Managing about $3 billion in assets and millions of dollars in annual local spend to the Chicagoland community. Dr. Gayle will be our speaker on around the efforts of the Chicago Community Trust to close the wealth gap. So welcome, Dr. Gayle. Dr. Frederick is an emergency room physician and has a 30-year history working in emergency rooms across the Chicagoland area. He was most recently the senior medical director for the Next Level Health Partners Health Plan. He's now a senior medical consultant. Emergency room physician work continues. But last year, Dr. Frederick published a paper in the Harvard Public Health Review looking at gun violence, health disparities, and wealth disparities. So, Dr. Frederick, really happy to have you. You're going to be our first speaker. So we'll be talking with you very soon. Thank you for coming today.
Thank you.
And then Professor Gregory Fairchild. Greg is associate professor at the Darden School of Business. And Greg is a foremost expert on Black wealth in America. So he will be responding to the comments made by Dr. Gale and Dr. Frederick. So we thank Dr. Fairchild for bringing up national expertise to this matter, and we look forward to his comments. Next slide. So I stole this from Dr. Gale, but it's a slide that we're all very familiar with, because over the last several years that I've been working in healthcare here in Chicago, you know, every other convening is about the social determinants of health. And, you know, what do we do? How do we fix it? People are making apps and they're creating whole new companies around this concept. So the social determinants of health include things like education, healthcare, neighborhood environment, social community context, economic stability, all influence a person's ability to manage or to deal with or to have access to the right social determinants, right? So this is a conversation that the Institute has been having quite a lot, and also other health folks, health professionals and tech professionals across the city. So we're gonna kind of take a different spin today, guys, and I'm gonna ask you to go with us here, because we should now begin walking into more uncomfortable conversations. If we're still comfortable, it means we're not making progress. And so we're gonna push the envelope in terms of how we think about, if we're gonna close these gaps, what do we really need to do in order to make a difference here? Next slide. So our first speaker is Dr. Frederick, and Dr. Frederick, you're actually running the deck here. So just before, you have some data you're going to want to share with us. Can you tell us a little bit about what made you do this study?
Yes, well, thank you for the opportunity. I was really keenly observing what was going on in my surroundings. I started working on primarily the south side of Chicago, in the emergency department about 33 years ago. And I was seeing patients that were very ill in large numbers with very advanced disease. And it struck me, working in a small community hospital, that was somewhat unusual, having worked at tertiary centers during my training, and not seeing the type of volume of illness that I was seeing there. So I started wondering, what was going on. In the meantime, CMS, formerly HCFA, started publishing some data surrounding Medicare discharges, patients that have been discharged from hospitals, so that hospitals could do a community assessment to find out what the needs were in the community. And came to find out that the area where I was working was an area that was kind of a hot spot for chronic illness, chronic disease. In addition to that, I started looking at some social science literature regarding segregation and historical contexts, law enforcement data regarding incarceration. And what really, I think, set it off was in January 2017, shortly after Donald Trump became president. He made a comment that he was going to send federal troops to Chicago to stop the carnage.
Dr. Frederick, you want to advance the slide? I think you list these points.
Yes, I'm sorry. So when President Trump made that comment, it struck me that people at the highest levels of our society and administration and leadership were not familiar with the root causes of violence in Chicago. So that's really what got this going.
Well, yeah, why don't you go ahead and walk us through some of the data that you reviewed?
Sure. This is from Illinois Department of Public Health. And what I want you to kind of focus on is sort of this pattern right here. This is going to be a recurring theme, but this is where the highest incidence of infant mortality is in the city of Chicago. You probably recognize some of these neighborhoods as being hotspots for infant mortality, probably not particularly surprised. But This is the data that I got from CMS. And this is looking at cardiovascular disease and kidney disease. When you go in certain neighborhoods, you can see DaVita and other dialysis centers almost as often as you see pharmaceutical stores or drugstores. And so this gives a similar pattern. And this is a map of life expectancy. So again, you see in the same pattern, very low life expectancy in these same areas. We looked at median household income and found that there was a correlation between median household income and life expectancy. And from the extremes, there's about a 16-year gap between the lowest level of life expectancy and the highest level, and it's based on where you live, what zip code you're in.
So, Doctor, can you just call out some of the neighborhoods in case people are familiar with them? I know that I can see the red spots on the slide, but can you call out the names of some of the neighborhoods impacted?
Sure. So here, for example, we're looking at Humboldt Park, West Garfield Park. This is on the west side. Austin is in here also. It's not, I don't think you can see the label. On this end, you've got Inglewood, you've got Greater Grand Crossing, South Shore, Roseland areas down here, Pullman. These are some areas where you see concentrations of chronic disease and also high concentrations of poverty. And incidentally, this is where most of the gun violence is going on in Chicago.
So Dr. Frederick, one of the things that when we were looking at our next level health data, we found, and you're even closer to this than I am, just an extreme burden of end-stage renal disease in our membership. Is that correct?
Yes, kidney disease really goes along with cardiovascular, renal vascular, and cerebrovascular disease. So vascular disease in general, we see a very high incidence in these same neighborhoods, and both affecting strokes, heart attacks, kidney failure. All of those are highly concentrated in these neighborhoods.
Thank you.
This is three maps looking at in the upper left-hand corner, or my upper left, years of life expectancy lost. And you can see the dark blue is where you have the highest loss of life expectancy. This is the infant mortality map again. And this is homicides. So this is where these shootings are occurring. And you can see the patterns are very similar across these maps. The other thing I was looking at was incarceration. And as many of you know, I'm sure the United States of industrialized countries, we have like the highest population of incarcerated people. 5% of the world's population is in the United States, but we make up 25% of the prison population of the world. In June of 2019, we had about 39,000 people incarcerated in Illinois. We had the 34th highest incarceration rate. There was a 300% increase in that since 1978. In Cook County in particular, we had about 18,000 inmates at that time. 73% were African American, 17% Hispanic, and 8% white. This is looking at the difference between what we spend on education versus what we spend on incarceration. In the yellow, you can see education spending. So in Illinois, we're close to about 10,000 per student versus incarceration, almost 40,000 per inmate is what we spend. So not surprising some of the results that we get with this type of investment.
So,
So in Chicago, I'm
so,
sorry.
so, so, Dr. Frederick. So, what made you kind of jump from the chronic disease burden to the incarceration burden when you were looking at this data? What drew you in that direction?
Yeah, that's a good question. My exploration of this went over probably a couple of decades. So this was not, something that just happened all of a sudden. So I had been kind of, it was sort of an iteration. I first started looking at the chronic disease issue because it struck me that I was seeing so many very sick patients. And then I started noticing that there were other issues, particularly surrounding public health that were also associated. And then I happened to run across an article, this article in particular, talking about $1 million blocks in incarceration, and found it interesting that the same neighborhoods where you have high chronic disease, high infant mortality, low life expectancy, you also have very high levels of incarceration. So it really was kind of an iteration of, the exploration.
So tell us what this slide is saying when you say Austin 550 million, Humboldt Park 293 million. What do those numbers mean?
Yeah, so Chicago has a distinction, what we call $1 million blocks. So these are city blocks in the city where $1 million or more is being spent on incarceration. In 2015, in the Austin neighborhood, $550 million was spent on incarceration. Humboldt Park, 293 million. North Lawndale, 241 million. So this is again looking at how are we investing dollars and what is the impact of those dollars invested. There's a striking relationship between imprisonment and poverty rates in the upper graph, unemployment rates, and youth asthma. So again, we're seeing sort of this cross-functional relationship between disease, illness, and social determinants of health, public health, and this incarceration issue.
So, Dr. Frederick, you started out though, you were looking into some data around gun violence, right? So that's something that people have really rallied around. But what is your thoughts now after you finished the study? Did it change kind of your thinking or why you? Because you said you started looking at data from across a lot of different places. I'm just curious. I know that in the ER you were seeing quite a bit of gun violence. Can you comment on the connections there?
Sure. Yeah, the gun violence actually for me was late. In other words, that was really the last thing that I looked at before I published the article. And it struck me that the patterns that we were seeing with gun violence very closely mirrored what I had previously been looking at in terms of chronic disease, infant mortality, low birth weight, and low life expectancy. So the striking and then the fact that it seemed that every time I would hear about potential solutions, it really centered around things like we need to have higher incarceration rates, we need longer sentencing, we need community policing. Everything seemed to center around solutions that involved police and law enforcement. And it struck me that law enforcement was really not the solution and is not the solution and will not be the solution. And so I wanted to see if I could demonstrate some relationship between what I feel is a public health emergency and gun violence in Chicago.
Can you go to the next slide, please? I'm going to put this up for Dr. Gale to kind of respond to. Thank you, Dr. Frederick. Dr. Gale, when you hear Dr. Frederick's presentation, this is one of your slides, and I like this slide. There's a name for this type of slide, and I like it. Can you talk about how you're taking in that data in the context of kind of the trust and where it's headed, or where it is headed, with closing the wealth gap.
Yeah. Could you go back one slide maybe and just, oh, sorry, and maybe in different orders, and maybe a slide further. Yeah, so, I came to Chicago about 3 years ago to be the head of the Chicago Community Trust. I had a long career in public health and then did global poverty work. And, for me, the first slide that you showed, the social determinants of health, has really kind of shifted me in a way from focusing on kind of pure health interventions to really thinking about this broader focus on the social determinants of health. And, we now know that up to 80% of what actually determines people's health are the social determinants, and that, medical care accounts for a much smaller portion. Obviously, medical care is important. Access to health is clearly important. But we know that the social determinants of health are actually what really determine people's health as well as life outcomes. So when I came to the trust, we really wanted to say, how can this organization's been around for 100 years, whose focus is how do we have a greatest impact on the Chicago region? And we looked at a lot of issues, and this kind of portrayed here. We looked at the issue of health. We looked at education. Obviously, violence is a big issue, homelessness, et cetera. But when we looked at all these issues that were key here in the Chicago region, we recognized that underneath all of those issues was this issue of the wealth gap, and a sustained and growing wealth gap. And if you go back to the other slide, Barry,
that's a word cloud, by the way.
Yes, word cloud.
Word cloud.
We asked ourselves, how did this wealth gap occur? And, what were some of the issues that defined it? And, clearly in this region, wealth is very much divided along racial and ethnic lines. And we know that African Americans and Latinx community have much less wealth, and this wealth gap is growing. And, if you look at it in any, slice it in any way, 2/3 of African American and Latinx households don't have enough money to last more than 3 months, if their income is stopped. And we've seen this through the COVID pandemic, how this, not being unemployed, not having access is, really having its greatest toll on communities of color, particularly Latinx and African American. So how did we get here? And this word cloud, has some of the ways in which we know racial discrimination and racism has had a huge impact on creating, if you will, the wealth gap that we see today, whether it's redlining and the fact that African Americans could not have the kind of home ownership that allowed people to amass assets and wealth, codified segregation, both housing as well as job discrimination, economic segregation, debt, poverty, immigration, particularly for Latinx populations, discrimination, Jim Crow, mass incarceration, et cetera. So we know that, in some ways, poor public policy created many of the conditions that led us to this wealth gap. And it's why we've said this will be our highest priority, because we feel like this is the way we can have great impact, not only on health, but on so many of the other issues that face the Chicago region.
So, Helene, I just want to, something that you said, kind of just highlight that you said policies. So the redlining was a federal policy, or
Yeah, it was a federal policy. It was codified.
Codified by policy. Jim Crow, I believe those were state policies, but it was widely practiced.
Right.
Predatory lending, were those legal things that they're doing? Those were legal?
Predatory lending is legal here in Chicago. The average interest on a loan from predatory lending is 400%. Imagine if you're a poor person and the only place that you have the ability to get credit is a place that lends you money at a 400% interest rate. That's legal. And we've got to work on how do we, and I'll maybe just shift to, some of the ways in which we're tackling this issue of the wealth gap. We have 3 different strands, and there's a slide in there somewhere.
Let's go forward, because there's some data that you looked at when the 400% was one of them. So I just want you to share this with our viewers. Just talk us through these next couple of 3 slides here.
Okay,
Data that you have.
So as I mentioned, we know that here in the Chicago region, wealth and the wealth gap is very much divided along racial and ethnic lines. And if we look at Black and Latinx Chicagoans who are living on the financial edge, a loss of income beyond 3 months would push them below the poverty line. That's 65% of Black and Latinx population compared to about 28% of white Chicagoans. Almost 30% of Latinx and Blacks have 0 net worth compared to 15. So that means 0, nothing in the bank if one has to do anything past the paycheck. And so this is really, when you talk about living paycheck to paycheck. I can go to the next one. And again, nearly 20% of Black and Latinx households are unbanked, which means if somebody has a sudden need and has to go to a payday lender, they have to go to somebody who has an annual interest rate of as much as 400%. So
and
huge impact on creating.
Yeah. Okay.
Sure. And it's one of the policies that we're working on is caps on predatory lending, which many states have around the country.
Okay. So next slide. Let's this is another one, and then let's move to, this is a bold move for such a large philanthropic organization to make, and I want you to talk about how you guys move. What was the interest and input there, but talk us through this one and then take us to that sort of transition.
Yeah, and I simply say, to point out that investment, particularly private investment, which we know is what really spurs economic growth, is disproportionately, those investments go to majority white neighborhoods. And as you can see, if you look at this per dollar and normalize around $1, if $1 goes to a majority Black neighborhood, almost $5 goes to a majority white neighborhood, and about $2 to a majority Latinx. So, almost a 5-fold investment in majority white neighborhoods compared to majority Black neighborhoods.
That's a pretty significant gap. That's a huge gap. Okay, now talk us through kind of where the trust is and where they're going. Doc, can you advance the slide, please?
Yeah, so, we developed this strategy with the goal of closing the racial and ethnic wealth gap, divided into 3 different strands. So increasing household wealth, driving community investment, and building collective power. And the increasing household wealth is really, how do we make sure that at the household level, people have the means to create asset and wealth? So increasing access to good, well-paying jobs that provide career opportunities, home ownership, entrepreneurship. We know that you can have an income, but if you don't have vehicles for turning those incomes into wealth through things like home ownership or entrepreneurship. And then also looking at debt, because we recognize, and again, looking at the predatory lending, that discriminatory fines and fees, payday lending, et cetera, all of these things create greater debt, student loan burdens. So we're also not only looking at how do you create assets, but how do you make sure that once families have those, they aren't taken away. Second one, community-driven investments, and just pointing out again that disparity between what's invested in white majority neighborhoods versus Latinx and African Americans. So we want to help to catalyze those kinds of investment. And then very importantly, building collective power at the community level. How do we make sure that the narrative, the voices of community are lifted up in the process so that communities are actors in their own future? And just finally, the next slide, I think, just shows some of the things in which we're going to hold ourselves accountable over the 10 years that we have laid out for the strategy around social and community drivers, as well as economic drivers, with the key goal of how can we actually have a tangible impact on closing this racial and ethnic wealth gap that exists in Chicago. And I would just, end by saying, a lot of people asked us, to your point, Cheryl, that, why are you focusing on this issue? Why should all Chicagoans care about this issue? And, if you look at the fact that 2/3 of our population are African American or Latinx, we cannot continue to move forward as a region if we're keeping 2/3 of our economic potential behind. And I think when we look at it is the right and fair thing to do when people have been left out of economic opportunity. It's the thing that will drive so many other factors, but it's also the smart thing to do if we want to continue to move our economy forward. We cannot move forward as an economy holding 2/3 of our population back. And we know that already. Chicago is 67th out of 100 of the 100 largest metropolitan areas in terms of economic growth. And a lot of that is because we're losing potential. And more studies are showing that the wealth gap is, if the wealth gap was reduced, we would add trillions of dollars into our economy. Here in the Chicago region, we know that we would add over $4 billion into our economy just by closing the racial wealth gap. So there's huge economic potential. And with that economic potential is also the fact that we would have better health as a result of it by closing the racial and ethnic wealth gap, because we know it's a key driver of health as well as other opportunities.
Dr. Gale, do you have any partners as a part of this vision and this program at the Trust?
Sure.
Are there others? Do you have national or local kind of big money support behind you? I know this morning at 3. Yeah, go ahead.
Yeah, I mean, obviously, the Trust is a key funding partner here in the region, but we can't do this by ourselves. So we have huge partners, large number of partners involved with us, other philanthropic players, the corporate sector, other private donors who are all working with us in this effort. And today we are going to launch an initiative with the mayor's office called Together We Rise, which is really looking at economic recovery for Black and Brown communities based on the COVID economic and health crisis. So we have a large number of partners. We're launching this initiative where we hope that we will be able to raise several hundreds of millions of dollars to be able to invest in those very neighborhoods that have been most impacted by the COVID pandemic.
That's great. And then in terms of policies, Dr. Gale, you talked about the payday lending. And one of the things that I've learned as I've sort of been an entrepreneur now, serial entrepreneur for the last 5 years, when you move money, there are people who get mad, right? Because someone's making big money off of payday lending. It could be large private equity firms who have rolled out this sort of program across the country, or other private investors. I mean, what's your thinking there? That you're moving cheese, and it's big cheese.
Yeah, well, I think overall we feel very strongly that, to the slide we started out with, that in many ways bad public policy got us to where we are today, and it's going to take good public policy to move the needle and be a huge lever for change. And there's a range of different policies that we're working on, everything from expansion of earned income tax credit, which we know has been a huge help in stabilizing working families' incomes, looking at issues of programs like child savings accounts, baby bonds, and other programs that could give children an opportunity to amass some assets by the time they're 18 years old because of accounts that governments establish for poor children. Everything from that to looking at payday lending. And that's a complicated one, as you mentioned. We both need to look at how do we look at some of the examples of putting caps on payday lending, but also how do we work with banks to be able to have more flexible lending practices traditional banks, so that people don't always end up with payday lending being their only option. So it's going to take, it will take some work. It won't all be done by us, but we're looking at a range of policies that we think can really help to close that racial and ethnic wealth gap, both by helping to increase assets as well as decrease debts. One tangible effort that we worked on here at the city level was some of the discriminatory fines and fees. We know that communities of color are over-ticketed, and that those tickets and the inability to pay and the increased debt that comes with those has a huge impact at the household level. So we've worked with the city and the clerk's office to really work on these issues of discriminatory fines and fees. So there's a whole range of things that we're working on that we think can have an impact on this wealth gap.
Wonderful. Really important work. When did you all launch this? I'm wondering when will be your 1-year anniversary of this effort?
We launched it about 6 months or so ago.
Okay. All right. So we're looking into.
We have work to do. We have work to do.
No, it's okay. It's good work, though. It's as John Lewis said, good trouble. This is good work on behalf of the city, and I'm looking forward to just hearing and following along with your progress, and also supporting it in any way that I can. I think it's good for our members to hear about this work. I'm hoping that I know somebody's already asked if they could get a copy of the slides. If you guys are okay, we'll be posting this on our website and also our YouTube page as well as our LinkedIn. So next slide, please. Dr. Frederick has there you go. So Dr. Fairchild, you've been, as my husband would say, sitting back in the cut, listening. As a teacher and a professor, this is, part of your work, taking it all in, and, you're responsible for educating you have educated a series of leaders in business over the years, including, I believe, the newest, you're close with the newest dean of the Wharton School, is one of your mentees as well. So,
are you trying to embarrass me, Dr.?
Well, I hope you'd be proud of that. She seems phenomenal, actually. But Dr. Fairchild, as you listen to, and you're at a school of business, one of the top 10 in the country. You're not from Chicago. You're in kind of Charlottesville, teaching, watching, listening back and forth between there and DC, and of course, speaking nationally on this topic. As a kind of foremost expert on Black wealth, when you listen to Dr. Gale and Dr. Frederick, can you respond with some of your thoughts?
Well, first of all, let me thank you all for letting me be here. I'm feeling like I'm the one who's invited to the party that doesn't fit. Nevertheless, I appreciate having the opportunity to talk to all of you about this topic. In fact, this comes from a place I've been living for the last 2 years, really. I'm a part of an effort of the Surgeon General, Jerome Adams. There's a report coming out. It's called Community Health and Economic Prosperity. Some of you are nodding because you already know about it. I'm one of the senior scientific editors on that report. And that report is central to this question of how community health and the economic underpinnings, including business interactions, really play a big role. So glad to be at this convening and glad to be with you. Also want to say, no, I am sitting in Charlottesville, that's true, but I spent a little time in Chicagoland, as you all call it. There's a little foundation called the MacArthur Foundation, and in 2008, they gave me a good bit of money that changed my career in terms of doing work on a topic near and dear to my heart, community development financial institutions, CDFIs, which I'll talk about as a part of the solution in just a minute. As part of that work, I spent a little time with a bank called Shore Bank and its founders, which many of you know, and also some of the other organizations. This was back 12 years ago. So I do know a little bit about Chicagoland, but I do also focus on the national question. So I appreciated Dr. Frederick's slides, for example. I look at some geo-targeted data myself. Let me be quick about some things. First of all, in hearing from our first two, let me point out that these problems are complex and nested. So Dr. Frederick's work is about a whole stew of things that come together to produce challenges in public health. Dr. Gale's points were that there are people that are having public health problems before they even get started. Has nothing to do with what they choose and how they choose to behave, but has to do with whether there is a grocery store down the street, whether their family has access to fresh foods, whether people have asbestos in buildings that are old. I could go on. You all are physicians, so you know this all better than I do. But let it suffice to say that the nesting of these things becomes very important. And then, by the way, the clustering of these problems in physical space. So Dr. Frederick's slides are about how what we have in our country is the reality that we cluster the problems in physical space. And so this produces what we would call a multiplier effect. If you happen to live in a place where lots of people are low income and lots of people don't have great health and lots of people have gun violence, that's another part of the stew that we're talking about. And then you add in that people are last hired, first fired. If you throw in that they aren't able to own homes, which are the number one component of wealth in this country, much more than stocks. So when you put that together, you find that we concentrate the problems in ways that make them worse for succeeding generations. The next thing I want to, could we page one, please, Dr. Frederick? The next thing, I think the good news is my colleague, Dr. Gale's already handled this, but this is the latest data from the Federal Reserve Board showing you the average, both the mean and the median net worth in the United States by race. You already knew it was fractional. She told you that. But you can see how fractional it is. Now, this wealth, by the way, includes housing. This is net worth. So this includes everything, a home, a retirement plan, stocks, cars, all of it. So at the median, African Americans, for example, are at $13,000. Again, I want you to note the means are far greater. All of us who remember this simply tells us that the means are almost 10 times greater than the medians, which tells us that the upper end of all of these wealth measures is quite high. I want you to also note, and this becomes important, the mean versus median multiplier for African Americans, for example, and for Latinos is greater than it is for the white population. So what that means, sports fans, is that there is more inequality in the African American population than across populations. Let me say that again. There is more inequality within the African American population than there is across populations. Just again, the disparities that have been pointed out, you can jump down from the 146.4 to the 13.6, but then look at the horizontal as well. Vertical is interesting. Horizontal has some interesting findings in it too. Let's proceed. So again, I think we kind of already dealt with this. We can roll these down pretty quickly, Dr. Frederick. All of the factors that drive wealth inequality are driven by segregation, though there are just a couple others that aren't. But here's what we find, and the social science data essentially has been distilling to the notion of what we call zip code destiny. Where you are, where you're born, plays a significant role in where you will progress in your life. And America has told itself for generations that we were the land of economic mobility. The data say that that's not true. Additionally, for my African American friends on the call, You may have the thought that the progression across generations, we've all groups in America have had this notion of with each successive group, things will get better. If you look at Raj Chetty's work, not only has this meant that we aren't getting better generation over generation collectively, some of you know, but for African Americans, if you happen to be from a very wealthy family, you might anticipate that your child will be too. The data actually show that that might not be true, and that the likelihood of a child slipping from, say, the upper quartile of wealth to lower quartiles of wealth for African Americans specifically is much more likely than for any other population. African American males even more specifically. So the picture I paint for you isn't a pretty one, but I'm a business school guy, so I'm not here just to present ugly pictures. I think what I want to do is drive down some of the things that the other colleagues here have mentioned. First of all, we need to think about targeting geographically problems and doing so in a comprehensive way. So if we took Dr. Frederick's slides of Chicagoland, we know that those same patterns exist in every city in America. In fact, if you go to the next slide, I'll show you an example. One more beat. These, by the way, are per capita incomes in the United States. And these data are at the county level. And you guys, I want to have you look at this slide and the next slide, Dr. Frederick, if you could hit it one more time. And these are places of fair and poor health in the United States. Look at, and Dr. Frederick, could you page back once more? I just want visually to show to the group that the places that are lighter of higher income, of lower income in this first slide. If you page back to the second slide again, Dr. Frederick, those are the places of health disparity nationally. So the pattern that Dr. Frederick showed for Chicagoland is the pattern. The reality then is that we're looking at a national problem, and we need solutions that, yes, deal with policy. But I'm going to come back to that thing I said, CDFIs. I'm a big believer in what we call intermediary organizations that do work and sit between capital and communities. And CDFIs, Community Development Financial Institutions, do that. They provide funds to, for example, clinics. I sit on the board of the nation's largest CDFI, LISC, Local Initiative Support Corporation. Significant organization in Chicagoland as well. LISC funds, among other things, community centers and healthcare centers around the country, educational initiatives, things that then target the types of problems that you all are interested in. One of the big issues when my friend Dr. Rucker-Whitaker says follow the money is that we want to follow the money, but oftentimes the money doesn't know where to direct the help. Those of us who've hit the lottery and have a bunch of money often don't know where to target our assistance or how to best deliver it. And so we need on-the-ground organizations that are good at that. CDFIs make it their business to transition that capital into the institutions that do good work and to measure that. And so I just want to say that moving toward ways that we engage these problems, we analyze them, we find where the problems are, we use the charts that Dr. Frederick mentioned. Yes, I'm not saying we don't do legislative solutions, but I'm a business school guy. So I believe we think about doing business solutions. That's just my leaning. I think two more things I'll add. Everybody on this call, I'm gonna guess if you're on this call, you were a lottery winner. You're on the front side of all those wealth numbers. So good for you, good for all of us. I'm happy for all of us, but I think that the larger question, at a certain moment, Dr. Gale said, we have to do something about it. I'm going to respectfully say that it might not be the case that we do much about it. I'm going to respectfully say that America could find itself in quite a demonstrably unequal, angry, dangerous society pretty easily. These problems have gone on for generations and people have known about them and we haven't done a lot about it. So I'm not as sanguine about whether awareness produces change. I think that we have to be about thinking through large portions of the society hit the lottery and don't have any desire to change it. Large of us are lottery winners who are just happy with the way it is. And so thinking through how we will do something about it and running against the stream, which will be going the other direction, will be a big part of what I've tended to do in my work and I encourage. So I probably said more than you want, Dr. Rucker-Whitaker, but I will back down now.
No, Greg, those are again sobering. I think, and as a physician who's practiced, we started in San Francisco, but moved here in the late 1990s to practice on the south side of Chicago, and we still live in South Shore, one of the neighborhoods hit most by COVID and by every single ailment that Dr. Frederick kind of highlighted. So I feel this at a very kind of visceral level here. Look, guys, we actually we have about 9 minutes. I'm just gonna some of the things in the chat. Dr. Chatterjee, we need policy and business solutions. One of the questions from Mark, some economists say human capital is a larger part of wealth than financial capital. Health and education are major sources of human capital. What do you think about kind of the sort of places to access human capital? Any thoughts there, Dr. Gale?
Yeah, and just one thing going back on what you said, Greg. If it sounded like what I was saying is that awareness will get us there, that's exactly not my message. It is that, and it's part of why we have the third stream of the strategy, which is really around community empowerment and making sure that in fact this isn't left to people becoming aware and deciding that all of a sudden what was in their best interest is no longer the case. So clearly, I don't think this is an issue of how aware people are. I think it needs to be much more intentional about that. Also, I believe the human capital argument, definitely, I think it's hugely important. But I think sometimes the human capital argument gets us to thinking about individual solutions. And if we heard nothing else coming out of the George Floyd protest, it is around a recognition that these things are systemic. And if we aren't changing systems and doing the hard work of what that actually means, and always continuing to focus on individuals, how are we creating programs for individuals? We'll continue to have what Greg mentioned, the lottery system of, some of us will do quite well, but it won't really change the reality of the numbers that we're talking about. And so we really have to think about this, not only from a human capital standpoint, but we also have to think about how are we changing the system, both for human capital, but largely the systems that have made sure that finances are owned and grown by a certain group of people and have obstructed access to capital, access to economic opportunity by others. So, I think it's both and.
Okay. Just a statistic here on the chat. The average payday lending statistics for minorities is a 394% interest on a loan. About 84% of borrowers reborrow, creating debt cycles. They pay the average of $1,320 in fees. Someone says human capital can be harnessed just through education. And we don't even have time to go there with some of the issues around unequal kind of public school access and issues, guys. I think if you want to do a session on that, send me a note, okay? And say, Cheryl, I want us to do something on education disparities and how it impacts health. So it sounds like we should also be working with Healthy Chicago 2025 as well as other partners. Agree. And one of the questions is, what are some of the solutions that the Institute of Medicine can assist with? Now, I'm going to just lean in, and I'm biased here, but I do think for physicians and nurses and those of us who work in the healthcare system, we do need to be educated on these issues. So I feel like part of the work of the Institute needs to be to educate us and bring us out of kind of our ivory tower. And one of the reasons I left academia is that I felt like I was benefiting from the sort of continued sort of outcomes based on segregation and other things. I'm writing and publishing and speaking, and I'm going, wait a minute, that's going to get me promoted, but that's not changing anything. And I want to encourage us to go to that uncomfortable place to begin to sort of make a difference as healthcare professionals, ask some of the hard questions. And then a comment here from Pat, the difference between possibility and probability. We need to work to increase the probability that we can get to equity. So thank you, Pat, for that comment. As our time is coming short, I knew that it would be tough to go through so much in such a short time, but just trying to be respectful of the amount of time we spend in front of screens and whatnot. We're going to thank our panelists, and we're going to thank all of you. I think we have a couple more slides. Dr. Frederick, can you advance? Oh, this is, you were already doing that. Thank you for doing that. Thank you for sharing your questions and your comments. I thank our sponsors again. Next slide. And I look forward to coming back to talk with you on October 23rd. I hope that you will all join us. So we have now what is really kind of a baseline or basis for the conversations we're going to have around COVID-19 and where it has brought us in 2020. But it's important to understand foundationally how we got to where we are. And now we sort of pick up on some specific things about how we go forward. We'll have a status of COVID-19 from the Director of Health for the state, Public Health for the state. We're going to talk about maternal mortality and morbidity, particularly in Black women, huge disparities. Really, it's a national shame, if you will. We've got to do more work, better work here with African-American women dying and more kids ending up in the NICU. I want to talk about that in the context of the various hospital closures on the south side of Chicago that all happened. Many happened this year, but in the years prior, some happened right in the middle of COVID. So we left these women with really nowhere to deliver, not a clear sort of what to do. Where's my doctor? These were things happening in real time. I want you to continue to follow the money, ask questions. Where are the dollars going? Understand that we are paying for what we are getting. So if the dollars stay where they are, there will be no change. So we have to really sort of decide if we really want change or we want to just talk about it, get promoted and publish in, academic journals. So I want, and I love academia, it's my home, but I'm challenging us to think bigger, think better, and to think towards change. And I think then we partner with Dr. Gale in her work. It makes it easier if, as healthcare professionals, we're able to kind of dive in as well and make the changes and support where we can make a difference. So with that, I'm going to just going to check the chat. I've got several folks thanking us. They want notification of the October 23rd meeting, and check our LinkedIn. Please join us on LinkedIn. Email Deborah Hodges to get you on our mailing list if you're not already. And I'm looking forward to our next convening. I want to thank you, Professor Fairchild. Thank you, Dr. Frederick, and thank you, Dr. Gale, so much for your time. Any closing comments? If not,
go forth and do good.
And make good trouble.
Yes.
We'll talk to you soon, guys. Have a great day.
All right.